Okay, so now we have time to further discuss. First of all, I mean, Kathleen, you have been running the largest TMS trial with cocaine use disorder.
Yes.
Do you want to share some of your experience in terms of running that, basically the largest trial, in terms of your concerns about the seizure and safety and the effectiveness?
Thank you. Yes, we are just in data analysis. We had a multi-site clinical trials network study of TMS versus sham for stimulant use disorder. So we got about half of the people with cocaine use disorder and half of the people with methamphetamine use disorder. The publication should be out within the next couple of months, but I'd say the safety profile was pretty remarkable. We definitely had no seizures. We did develop, I do think that, I think some people do find it more uncomfortable, but maybe that stimulant people are a little more sensitive, but we started out just going full dose and ended up after the first few people getting feedback and implementing a ramping procedure. And then we've also, we would check their motor threshold every month or so, but if they came in and they either reported use or had a urine drug screen that indicated use, we would recheck the motor threshold then as well.
But you have not been excluding them because they have been...
No, we didn't exclude anyone. They could be active users at the time they came into the study. So we did not exclude them, and we've got plenty of urine drug screens throughout the study that were positive. So so we'll have a lot of data. So we're really just looking at the efficacy stuff now, and certainly tolerability is a big part of it, and feasibility dropout. The cocaine people hung in there. 80% of them completed this 6-week protocol and got somewhere between 20 and 30 sessions of TMS. Methamphetamine was harder. We probably had more like a 50% dropout, and side effect profiles were similar between the two. No seizures, but we did have some. I can't remember. I wish I could think of the terminology. You guys know, like it's side effects are one thing, but then things that are determined to be specifically specific to the treatment itself. Like, did people report treatment emergent headache? Anyway, we had
adverse events?
No, they weren't adverse events. So it was literally to do with the things that were determined to do with the treatment. And so we're in the midst of analyzing that.
Expected side effects, like device related.
That's what it's device. Thank you very much. I was blanking on that. I was trying to think of what it was. So we do have some device related information that. Which is a little bit higher in the TMS and the placebo group, but I'm sure that's true for depression and for anything else. So.
Which machine protocol were you using?
We used the BrainSway.
And was it accelerated or which?
No,
Which coil is it? The singular coil or the insular coil?
The singular, I think.
H.
Yeah, H.
Well, they're both H coils, but they make a singular coil and they make an insular coil. The smoking cessation study that got approval was the insular coil. Yeah.
You are targeting DLPFC.
Yes, we were DLPFC was the target.
So that would be the singular coil.
Yeah, I'm pretty sure we used the singular. Yeah. What was your question?
Which protocol were you using?
We were very flexible. So but people could get up to 3 treatments in a week. So the idea was if we could front load it, we would, and but they couldn't get more than 3 in a week. They had to have at least 1 a week.
And intermittent, not continuous, right? The intermittent.
Yeah, I mean, no, we used the 20. Yeah, I think we were using 20 hertz. The 20 hertz RTMS protocol. So we tried to be as flexible as possible. The idea being, but I'll tell you, from the signal we got in methamphetamine dependence, I'm super interested, and we're putting in a project to look at accelerated, because they dropped out, but when they were in, they did well. I mean, they really, so it looks like something more accelerated would probably be much better for that group where compliance is clearly an issue.
And before, go ahead.
Intranasal cocaine or crack?
Both. Yeah, we sort of took all comers, but we'll have that information. Yeah, I think most of it was intranasal, if I'm not mistaken. I have to look at that, but yeah.
Was there data collected on like time of last use, date of last
Yes,
use?
we've got all of that. Yeah, we have all that stuff. So that will be, and you know, when everybody came in, we asked that. So I can't remember if the use had been within 24 hours. We definitely redid the motor threshold. So that's the other thing we'll be looking at very carefully because we've got hundreds of sessions across all these folks. So it'll be interesting to really look at the relationship between proximity of use and does it change the motor threshold. We have that data, and yeah. So.
And the result?
Well, that's true.
Yeah. But the major issue is they haven't asked people to stop
No, we
taking
do not.
substances. So they have been active substance users and they have been receiving treatment. And that is the reality that we do. I mean, comorbid psychotic disorder for people with substance use disorder. So we do not ask them, okay, you are supposed to stop your substance use, then I will treat your depression. So that is not the way that it works in the reality of the clinical practice. And the challenging part, I can show you one specific slide that we had. I mean, we have been discussing about that with Victor, just yet. And then we have been kind of looking into the protocol. There are different components there that we didn't like. For example, I mean, the guideline was if they have currently active stimulant use disorder, that is contraindication, unless they stop taking that. So we have been thinking that is just too much, and just basically that would be a barrier for people.
This is in the treatment of depression.
That is for treatment of depression. And we have been discussing that. I mean, that is, and this is not, I mean, and then it was just the same situation.
What's the rationale for that proscription?
So we can discuss that. And also, I mean, for cannabis, if you are using prescribed or medicinal cannabis, you are fine. But if you are using recreational cannabis, it's contraindication. So
what's the risk?
Right. What is? Yeah. That's.
And that is the reason that we have been discussing with Dr. Tang in terms of, and fantastic, I love him. He's just a fantastic guy that he's always receptive. We have been discussing, I mean, that is the reality of the interventional psychiatry community. And the reality is, but because we do motor threshold, we optimize the dose to just prevent putting too much energy to put people in seizure. So we take all those things to consideration. So these are the components in that specific guideline that we have been thinking, okay, I mean, as addiction psychiatrists, our voice should be heard as well in that sort of community, because that is preventing people to have access to something that is evidence-based. And in my clinical practice with interventional psychiatry, I mean, TMS really works. So this is something that I'm super happy to put any family member to receive that treatment. And now it can be used for even adolescents age 15 years old. And that is also another opportunity. I mean, there are many opportunities that you really do not want to take that opportunity from your patients. And that was a discussion in terms of, okay, now we need to think about how we can put our forces together. We have been discussing that with Dr. Brady and others in terms of how we can have a guideline in collaboration with ASAM, AAAP, and others. And Dr. Tang is also very happy to support that process, working together to see how we can bring our kind of knowledge and also think about what is going to be the next step. So, and Dr. Tang, please.
Yeah, so I agree. As an addictions doc, I bristled at this. I think one thing to mention is, I'm reminded of, I was reading this paper surveying kind of like college students and whether they thought that cannabis helped with their ADHD symptoms. And basically all of them said, yes, it did. And so the paper concluded that, maybe cannabis helps with ADHD symptoms. And I think the limitations of this methodology is apparent. And so this is kind of the limitations of this methodology as well. So we did a Delphi panel. I don't know if anybody has ever done a Delphi study before, but essentially you bring people together and then they have to agree on a certain thing. And so we brought together people that did RTMS for depression. I mean, primarily we talked about OCD and all this kind of other things. And the idea was, how do we make them agree on what you do with substance use disorders? And so, that was basically kind of like the needle kind of movement, right? So you take all these movement disorders people, and mood disorders people, and then ask them about their expert opinion to people that are like them when it comes to managing substance use disorders. And I found it was a challenging process, and it was hard to get consensus and these kinds of things. And it's kind of like what I was saying with the meta-analyses, right? Like you get these distilled kind of guideline statements, but everybody had to make these little compromises in order to reach that Delphi. So it was an interesting process, and I don't profess that like any of these things are like more than what their methodology was from the beginning. The other thing that I wanted to note about the specific wording is that we really tried to, wherever we can, put clinical judgment at the beginning of everything. So it was 3 times a week or whatever, and signs of problematic substance use, right? Or and it was like that for everything else. And then we talked about how that problematic substance use makes it so that A, the risks outweigh the benefits, or B, the other thing we talked about was kind of the difference between efficacy considerations and safety considerations. And so, for example, the cannabis one, while there may be not as many safety considerations, it would be an efficacy consideration. And so, a lot of mood disorder psychiatrists and, in the concurrent disorder space, like, I believe this too, is that there's a big confounding and depressogenic effect with cannabis on mood symptoms. And so, for the people in that Delphi panel who were very judicious about the evidence, it was like, well, if cannabis has a huge depressogenic effect and the people continue to smoke cannabis to a certain amount, and yes, the 3 was like arbitrary, but it kind of was this like, blurry threshold for like they're smoking a lot, they're smoking most of the time. How can we assure that it's efficacious? And this whole thing about do no harm, and do no harm as in do no deliver, like kind of questionable efficacy. So that was the rationale. I'm not sure if I was by myself in my own clinic and I'd made all the shots that I would follow that, right? But again, when the consensus comes together, that's like the middleiest ground that we could get. Right.
And at the end of the day, it's always important to have addiction psychiatrists who know interventional psychiatry, and they can just cross the bridge and just make sure that in our clinic, other interventional psychiatrists, when they have some like a complex case, they say, okay, just send it for Hamid, because he is happy to manage cases that they are using substances, and he is happy to kind of, and even in addiction psychiatry clinic, then I can see lots of patients that they have been receiving different medications, they have never been responding, and they are still depressed, and then I say, okay, you are definitely a good case to receive TM. So you can just bring both sides together.
Exactly, and you need someone like having Hamid there,
Yeah.
Otherwise they'd be really freaked out, right?
Right, so if I could just make one more comment, and then I think Dr. Marienfeld has been standing for a while, but I just want to say one thing about, I don't know, there's very nice data from Greg Salem that TMS actually works in cannabis use disorder, and based on that, we're about to start, we've got a CTN approved protocol in cannabis use disorder. So maybe if people didn't think it was contraindicated, the depression might actually improve because the cannabis use goes down. So I guess my only thought is, and I think Hamid was saying this, I think what this means is there needs to be cross-pollination, especially if you're talking about exclusions that have to do with the disorder that you don't really know anything about, or not much. So that would be my plea, is that we had more involvement of addictions people in the development of those guidelines, especially around those exclusions, I think.
Interestingly, there is an RCT in the field of depression that they showed that adding D-cycloserine can make the efficacy higher with TMS for depression.
Oh, is that right? So that's been established.
Yeah. That is something that is already approved. The evidence for D-cycloserine, the least amphetamine or Vyvanse is just a little bit kind of lower, and I was discussing with them in terms of if you want to keep one of those medications, probably D-cycloserine is, or any sort of glutamatergic things that could enhance that sort of a specific pathway.